Well, we had a terrific AML session with some of the leading experts from around the world talking about different types of approaches to treating acute myeloid leukemia. We started by focusing on probably the most common type of acute myeloid leukemia that occurs in older adults. That's acute myeloid leukemia associated with specific genetic changes. And those genetic changes aren't things we're born with. They're things that occur that cause the leukemia to develop. And for that population of patients, we talked about treating the acute leukemia in the inpatient setting, so people are hospitalized for 4 to 6 weeks. And then we also talked about treatment options in the outpatient setting, where patients receive about a week of injections and they receive a chemotherapy pill long term. Next, we talked about treatment of acute myeloid leukemia that's particularly good risk, which can occur in older adults, which we tend to treat with chemotherapy in the hospital or considering giving chemotherapy as an outpatient again. There's a new approach to monitoring acute myeloid leukemia that's called measurable residual disease, where some of those genetic alterations I talked about can actually be followed over time to see if they disappear. And finally, we talked about bone marrow transplantation for acute myeloid leukemia, which we sometimes offer when people first enter a remission, or we sometimes save for when patients have acute myeloid leukemia that's successfully treated, but then comes back. In the initial discussion with the doctor, what I encourage my patients to do is to talk about their goals of care. What do they want to accomplish in treating their leukemia? Or is their goal to not treat the leukemia because they want as little contact with a hospital or an outpatient clinic as possible? Once someone has been able to define his or her goals, then they can have a more informative conversation with their doctor and the healthcare team about what types of treatment options they might want. For example, a patient who says, I would do anything under the sun to get rid of my leukemia and live as long as possible, might be thinking long-term about a bone marrow transplant. And if that's the case, we might offer more intensive strategies to treat the leukemia to get that patient to a transplant. Alternatively, I have had patients who say to me, I've been sick with other illnesses in the past, even treated for other cancers, and I've decided I don't want to go all the way to a bone marrow transplant. And in that case, certainly that person would not be offered inpatient intensive chemotherapy because that doesn't align with those goals. So my bottom line is, think about your goals, think about what you're living for, think about your quality of life and what you want to accomplish in the next few months, and then let that be the basis for the discussion you have with your healthcare team. Well, we have some terrific new therapies for the treatment of acute myeloid leukemia with a lot of approval of drugs by the FDA over the past few years. One of the major focuses of drug therapy and the recent approvals has been targeting specific mutations that occur within the leukemia cells. Some of those mutations might include FLT3, and all of these mutations are combinations of letters and numbers that don't make any sense. So a FLT3 mutation, which can be targeted with now 3 different types of drugs that are referred to as FLT3 inhibitors. Patients may have IDH1 mutations or IDH2 mutations, which also can be targeted by new drugs. Or they may have a mutation that's referred to as KMT2A or NPM1 that can be targeted with menin inhibitors, the most recent type of therapy approved for the treatment of acute myeloid leukemia. So as you're talking to your healthcare team, ask about the mutations that are occurring, the genetic alterations in your leukemia cells, and whether there may be a targeted therapy so that your treatment can be personalized.